Thank you for coming to the final session of the 3-day event here. Such a distinction. But I'd like to talk to you about a subject that sometimes is a real pain in the neck from the pharmacist viewpoint, because these patients often present with complex medication regimens that predispose them to some real drug-related problems. I'm going to speak to you this afternoon about medication use in chronic neck pain. And is it a risk or a benefit? And we'll talk together through some problems, and you can decide for yourself. Why are we going to discuss chronic neck pain this afternoon? Well, first of all, it's a very prevalent and potentially disabling condition. And it's also costly. It's been estimated that this condition results in over $51 billion spent annually in different treatments in the United States per year. And it affects the quality of life for many of our patients. And it's a reason for seeking medical care in clinics and the EDs throughout the country. And also, it's a condition of high medication use, which I'll share with you. First of all, you have to understand the area in the anatomy that is involved. We have here the superior nuchal line and also the spine of the scapula and the superior border of the clavicle and the suprasternal notch. This is all involved in the area of chronic neck pain. So when your patient states they suffer from chronic neck pain, they could be talking all the way up here to this nuchal line, or they could also be talking about this area here to the sort of the upper mid-back region. So this is the anatomic region of the neck to extending to this upper back that could be involved. So you have to ask the patient really what area is involved in this chronic neck pain condition. And this is from the Task Force on Neck Pain and Associated Disorders. This task force has been studying this condition for the past 10 years, and their findings are published in that reference for your review if you are so inclined to investigate. So as pharmacists, why are we interested in this condition? Well, self-treatment is very common. In your practice site, you may have patients looking through your OTC aisles or your supplement aisles, looking at analgesic remedies just for this condition. We have found that alternative therapies are extremely common in analgesic remedies for analgesic use in this condition, as well as physical therapy and exercise. OTC analgesics, vitamins, herbals are commonly sought out for use by these sufferers of this condition. These patients often suffer from co-morbidities, and they frequently use non-analgesic therapies as well. Many drug-related problems occur because of the complexity of therapies that often are concocted by these individuals in an effort to get relief. Now, these patients are often prone to quackery in a well-meaning attempt to get relief from their ongoing pain. Now, this I ran across on the MSN browser. It was a part of a Gallup poll survey that it was found that chronic pain affects almost half of U.S. adults, well, no surprise. And it was a survey, and it was found that 31% of U.S. adults have a painful neck or back condition. And 1/3 of these persons are in their mid-50s or older, and they suffer ongoing back or neck pain. And as my mother always tells me, you're getting older too now. Well, yeah, no surprise. And we are going to be faced with the population coming to us as healthcare providers and seeking our recommendations. And surprisingly, in one of the little pop-ups, there was this ad for the back relief belt. So again, this population is very vulnerable to these quick relief types of ads. Now, another concern is functional impairment with this population. Since it's so prevalent, affecting 15% of women and 10% of men, with an annual prevalence of almost 0.5% of the population, functional impairment to the point of not being able to perform child care, adult care, are part of your work. Patients tell us they're not able to sit at their computer, they're not able to drive. This is an ongoing concern. Cost to society, 5% of patients with chronic neck pain have a permanent disability. This is out of a study from Saskatchewan, and it is overall thought that chronic neck pain is second in job-related disability only to low back pain. And disabling neck pain is also associated with cardiovascular disease, headache, GI problems, low back pain, and depression. Factors that predispose patients with chronic neck pain to disability are thought to be prior neck pain, of course, female gender, lower educational status, high somatization, a higher pain rating, using the numerical rating scale. How do you rate your pain? 0 is no pain, 10 is such bad pain where you go to the ED to seek treatment. A higher level of disability where you can't function during the day, and the presence of sleep problems. Our objectives today are here, and they're probably pretty aggressive considering our time limitations. We're going to describe the types and frequency of medications and supplements used by these patients with moderately to severe chronic neck pain. And we'd like to identify some drug-related problems, or DRPs as we call them at Wayne State for our students, including inadequate pain control, which is a very common one with these patients, drug interactions, which is of main interest for us pharmacists, drug-disease interactions, and therapeutic duplications for chronic neck pain. And we will describe for you how to develop a safe and effective pharmacotherapeutic regimen with appropriate education and counseling for a patient with chronic neck pain. This is a case from practice. This patient is a 57-year-old white female. She was overweight, came in and wanted to take omega-3 supplement, OTC, and because she heard from Dr. Oz that it would help improve her circulation. She had pain in both her legs, and she was a counselor in an academic university, and she sat most of the day, and she was participating in a yoga class to help improve her exercise tolerance. Her past medical history included chronic neck pain for 7 years. She was an insulin diabetic, a dependent diabetic, just diagnosed two years ago. She had hiatal hernia, hypertension, she's postmenopausal. She drank occasionally, socially, and she had no known drug allergies. Her meds, she took Lantus insulin, she took ranitidine, 150 milligrams, as needed, of course, and she used a bivalve patch twice a week for menopausal symptoms. She would take ibuprofen or Anthrax OTC as needed for her neck pain. She had sleep problems related to pain, so she would use alprazolam, Xanax, as needed for insomnia. She would use Xanaflex, tenazidine, an antispasmodic muscle relaxant, as needed for a muscle spasm. She said at work when she sat at her computer, she would get all stiff. And she would take vitamin D3, 1,000 units daily, because she also heard from Dr. Oz that's a good idea. And her antihypertensive was lisinopril, 10 milligrams daily. And after we talk about the strategies for these patients, we'll come back to her at the end of the discussion. Now, the pharmacist's role in management of these patients in an interdisciplinary team, and much of what I do in my practice in the chronic pain clinic at Children's, which is basically the same for adult patients, is to take medication histories of these patients as they come into the practice site to avoid adverse drug reactions and drug-related problems. We as pharmacists, we're clinicians, and I know this has been mentioned by other presenters during your weekend seminars. We can conduct basic pain assessments. There's no reason why we can't. We need to screen patients' medication profiles or medication use and monitor, particularly for adherence. And basically, we need to ask patients to bring their medication in their bottles to the clinic visit. So many times I ask them, tell me how you take your medications, and then I do a tablet count, and I find out that if there's a mismatch. We can develop pharmacotherapy care plans and dosage schedules that can be carried out with respect to patients' lifestyles. And we are much better suited to do this than the physicians by virtue of our training. Patient education and counseling is really a must, especially with respect to the differences in cultures and differences in the patient's literacy. Where I practice, there is only a 47% literacy rate, and this needs to be taken into account when we carry out patients' education and counseling, and this is where my students come into a great help. We do different kinds of scheduling and dosages, though what I find that no matter what the patient's literacy level is, they all have a smartphone, and we can always program the scheduling into their phones. So we can always look and monitor adherence and pain scores using different technologies. What we need to also do too is to look at preventing ED visits due to poorly controlled pain. I looked at the different levels of costs associated with ED visits in the Detroit Medical Center for poorly controlled pain. If a patient goes into the ED for poorly controlled pain, it can result in anywhere from a $500 to $5,000 charge just for ED costs alone. And so many times when I reviewed the record, it could just be due to a medication adjustment in terms of drug optimization, dosage change. Many times it's an accessibility issue with not being able to find their prescription. So we need to, as providers, look at preventing emergency department visits during the patient's exacerbations of pain. And this can also be done with referring the patient to a multidisciplinary team early on in their pain condition. Also, this feeds into appropriate referrals. But I may be getting ahead of myself here. So, Drug-related problems, if you were more from my generation, when the drug-related problems were first described by Strand in 1990, I had to learn this because when I went to undergrad pharmacy, drug-related problems did not exist. But a drug-related problem is when a patient experiences or likely to experience either disease or a symptom having an actual or an expected relationship with a drug therapy. And basically it's a systematic way of approaching a review of drug therapy, and it focuses on a patient need or outcome. I was talking about the origin of drug-related problems with a student the other day, and she said, wow, I wasn't even thought of yet. And a pharmacy resident said, in 1990, I was still playing with Legos. I said, all right then. And also a drug-related problem is an event or a circumstance that involves a patient's drug treatment that actually or potentially interferes with an achievement of an optimal outcome. And I just put this in here for your review in case you're more from my era where drug-related problems just aren't second nature, to think of it that way. We all look for drug-related problems, but we may not define them as such. So classification of drug-related problems can be an untreated indication, drug use without indication, improper drug selection, subtherapeutic dose, adverse drug reaction, overdose, failure to receive a drug, or a drug interaction. As pharmacists, looking at patients with pain, we can assess, document, and intervene. Now, the Joint Commission states that patients have a right to pain assessment and management. And when we look at the pain scale scores, 0 is no pain, 10 is the worst pain that the patient has ever experienced, where they would go to the ER to seek treatment of their pain. A patient's scale score at midpoint would be 5 or above, or a patient just states their pain is inadequate. What do we do then as pharmacists? Well, our ethical obligation is to review their current pain therapy and to intervene to improve their pain. We need to stop. We need to see, number one, are they taking the medication as prescribed? Number one, I even ask the patient, are you taking the medication? Tell me how you're taking your pain medication. Then you need to look at, is the medication appropriate for the patient? You need to start problem solving. Is there malabsorption? Are there drug interactions? And also, what else is new in terms of pain assessment and management? Pain is not the 5th vital sign. How many of you knew that? Okay, some people knew that. Because what this has happened when people were aggressively monitoring pain as the 5th vital sign, patients were becoming over-monitored, overdosed. So now pain is to be monitored on a regular basis prior to the administration of an analgesic, after the administration of the analgesic, with each new report of pain, also with a new treatment, or when a patient is admitted to hospital, or when a patient is discharged, but not with each vital sign. It's not the 5th vital sign. This is just the regular pain assessment scale that we can all use for our patients. 0 is no pain, 10 is the worst pain. Tell me where you're at. Now this is the Neck Disability Index. It's a 10-item questionnaire. This is how neck pain is assessed, the effect of it basically on a patient's life. And this is how physical therapists will look at a patient, or physicians will look at how disabled a patient is from their chronic neck pain. And there are sections and sections of this for driving. There are sections for sleeping, work, concentration, headache, reading, lifting, personal care. There's even one for child care, or let's say someone doesn't have a child, but they take care of an adult. There is one for that. And this is a validated tool back from 1991. And surprisingly, the Neck Disability Index does not correlate with the numerical rating pain scores. This is one where you'll say to someone, about driving, I could drive my car without pain. Neck pain, I cannot drive my car at all. This is basically a section the patient would be evaluated when they go into physical therapy. And then while they go through treatment, they would be asked, while they're going through their exercise therapy, or let's say we would institute a certain regimen of medication therapy, psych therapy, relaxation, and we would then retest maybe in 6 weeks. Okay, can you, let's see, move from maybe I can drive my car as long as I want with moderate pain. Maybe they could drive my car as long as I want with slight pain. Now, when do people seek their care? What factors prompt them to seek care for their chronic neck pain? Well, perceived severity. The more severe pain you're in, you're going to go and seek care. Speed of onset. The faster your pain occurs, you're going to go and get care. Trauma. If your pain is from, let's say, an accident, whiplash, you're going to go and seek care. Previous experience, if you've had a previous neck pain experience, and if you have insurance that's going to cover your cost, you will go and seek care. This is what the literature states. Medication use. Now, believe it or not, because the data, there's a paucity of data describing medication utilization, safety, and efficacy for chronic neck pain. Even though this is such a chronic condition and it's so prevalent, the literature supports exercise, and the trials are all on exercise. And medication use is really sort of a second thought. And many times it states, yes, patients are on medication. Or physical therapists, they will ask the patient, are you on medication? Yes or no. Or many times the physicians will take a medication history. It'll say narcotics, NSAIDs, classifications, but not itemize the exact type of medication, what type of NSAID, like PMR, NR physicians. So many times, these intervention trials, the analgesic use is not reported. So we actually don't know what types of medications these patients are on. However, when patients do go and seek treatment, the non-opioids are used, local anesthetics and injections, and sometimes corticosteroids added to the local anesthetics have been used. And these have been the most successful in giving long-term effect. Short-term opioids have been used, just short-term with some effect. Long-term, they're not recommended. There aren't many data supporting the use of any of these agents, the non-opioids. But these are the classes, if you look in the literature, these have all been mentioned, non-opioids and opioids. But this is basically what constitutes pharmacologic management of these agents. Now, the role of opioids for chronic neck pain, evidence for use. There's not much evidence for use. Short term, yes. Patient selection, immediate post-trauma, there is a role. Long-term, the selection of patients, long-term, where there's no other response to any other therapies, sustained release, opioid like tapentadol or tramadol may be recommended, or perhaps methadone, but there is no support for the role of opioids in chronic neck pain. And then we have to look at appropriate monitoring of these patients. There was a Cochrane review in 2006 that shows that there's really no improved outcomes in chronic neck pain for these patients. Opioid treatment guidelines. Chronic neck pain falls under chronic non-cancer pain, and these patients need to be monitored for high-risk behaviors. We have to look at their MAPs upon every clinic visit and assess them for abuse potential and escalation of dose. Pharmacologic management, supplements, vitamins, herbals, complementary alternative medications, and hormones have been identified and used without much support. Non-pharmacologic therapy, early physical therapy is the goal for these patients. Passive modalities, heat, cold, massage, mild fascial release, traction have been used. Active rehab, stretching and strengthening have been most successful. Occupational therapy, and then the goal of independent home or community fitness after formal physical therapy is the goal for the patient after progressing through early physical therapy. Now, how do individuals with chronic neck pain use their medication? We really don't know. So we looked at patients in the Detroit metropolitan area, because basically the frequency of types of medications in our current local population, it's unknown. And I partnered with a physical therapist because I kept getting calls from a physical therapist at college. She said, I think physical therapists should be able to adjust medications for patients. Think about it. They spend a lot of time with us. She said, and acetaminophen is just acetaminophen. It doesn't have much of an adverse effect. She said, patients spend sometimes up to 12 weeks with us. They really get to know us, and they come to us, they often feel worse after spending time with us, so we should be able to tell them how much analgesic to take. They really don't need to go and see a pharmacist, and why should they go and spend more time at the physician's office? It'd be much more effective if we could do this, develop an algorithm for us. I said, why don't I work with you? Develop a multidisciplinary approach. She said, I have this study going on where I have patients with neck pain randomized to yoga, Pilates, or a control group. I said, why don't you let me see those medications? So I thought, can't beat them, let's join them. So I said, let's look at the types of frequencies of supplements used for chronic neck pain and comorbid conditions, and let's look at some drug-related problems. I'll show you why you need this pharmacist. So she had individuals 50 years of age with chronic neck pain enrolled in an exercise study, and it was approved by the IRB, and she had flyers going out, emails, and web advertisement to some urban and suburban community centers. And you had to have chronic, mild, or severe neck pain, cervical neck pain, and you had to have at least 3 out of 10 numeric rating scale for greater than 3 months, and you had to be greater than 50 years of age. And the exclusions, you couldn't have spinal fractures or neural kind of compression, like if you had numbness or anything, we threw you out of the study. And if you couldn't like give us a pain scale, or you couldn't like take part in the exercise studies, we said no, you couldn't participate. So we did a questionnaire and a face-to-face testing session, and we asked you about your supplements and your vitamin use. And we asked you about your medical diagnoses, and we gave you like an 11 point, a 0 to 10 numerical rating scale. And we asked you about your pain over the last week, and she did the Neck Disability Index, and we asked you about the number of prescribers you went to, and I also said let's do about adverse drug reaction history. And then I went and I classified the medications using the American Hospital Formulary System, and I looked at how many analgesic supplements, vitamins, and comorbid meds. And then I looked for drug-related problems. And like I said, oh, let's look at drug reactions, interactions, and I looked at lexicons online, and I used some primary literature, and then I did descriptive statistics on everything. We enrolled 64 patients, and I found they were sort of older, but I don't think they were really older. They're sort of like around my age, sort of young. I was amazed how young they were. And, but the range was 50 to 70 years. And they're primarily female, which, you know, the studies show that mainly female are suffering from neck pain. And so they were menopausal. And we screened them for osteoporosis status. And the majority of them knew if they had osteoporosis or not, and only about 4% did. They were like an enlightened group. The duration of time they're in pain, look at this. Some people have 50 years of neck pain. Look at that. But look at the variation. Some of them suffered for, you know, an average of 9 years. They said they were in pain 5 days a week. And 42% of them said they were in constant pain and overall pain. 8 years, but, you know, plus or minus, you know, almost 9 years. Majority of them attributed their neck pain to arthritis, as we'll see here. Some of them had whiplash. 11% had whiplash, which was, you know, from an accident. Pain on test day, 5. Average was 5. And the NDI scale, they said they had mild to moderate disability. We were trying to get moderate to severe. And they said they waited till they were like in about a 6 to take medicine. And then pain after their medication, they got down to about a 3. Some of them went to about a 10, a range of about a 10 still after medicine. We had 3 of them who had pain 10 out of 10 after they took their medicine. They said nothing touched them. So, what I thought was interesting, 70% of them had comorbid conditions, GI distress, hiatal hernia, ulcers, arthritis in other areas, okay, hypertension, look at that, thyroid hormone imbalance, hypercholesteremia, okay, that's fine, joint pain in other areas. You know what, there's a paper out too that shows patients when they're in pain, their hypertension meds, the need for those go up. How am I doing on time? What time is it? Okay, good. Thank you. Anyway, anxiety, depression, let's see, we'll look at that in a minute. Now, common conditions related to pain, depression. 6% antidepressants only, so there's sort of a mismatch there. Insomnia, that commonly accompanies pain. And only 14% were on sedative hypnotics. Anxiety, 13%. And 8% were on benzodiazepines. But they're an older population. Should they be really on benzos anyway? Interesting group. Medications for comorbidities. The most common one was thyroid hormone, which you probably see in practice, a lot of thyroid hormone among older patients. Antihypertensives, 29%. Statins and cholesterol agents. So, when people were saying joint pain, overall joint pain, first thing I asked them, what kind of statin are you on? Don't you think of that sometimes? Someone complains about joint pain, hip pain, you look at the statins. Someone's still on one of the older statins. Now, you're looking at patients who are taking NSAIDs for comorbid conditions. You wonder how many of those are the ones that complain of GI distress as well. Proton pump inhibitors and H2 receptor blockers, 14%. Yet 70% of that group are complaining of GI distress. So I thought it was interesting. Now, the duration of comorbid medications was 7.5 to 9 years. Some of them were taking meds for 38 years. Now, herbal supplement and vitamin use. Look how many are taking vitamin D3, 20%. Now, there are support in the literature for patients with chronic pain conditions to supplement with vitamin D3. It will not reverse the painful process. However, if you are suffering from a musculoskeletal condition, if you have lower serum hydroxy 25 hydroxy levels, the vitamin D3 levels, you need to supplement with vitamin D3, and it will improve joint and muscle function. So this is probably substantiated very well, to improve joint and muscle function. Other vitamins, 16% A, B, C, and E. Vitamin H, biotin, we had 5% on vitamin H biotin. Supplements, omega-3, probiotics, protein, chondroitin for arthritis, which there is some proof in the literature, to support herbal products. Chinese herbals, 9%, and there's no support in the literature for chronic neck pain. There are some data in the literature showing hypoglycemia associated with the use of Chinese herbals. We had several patients on elements, calcium, iron, magnesium, and zinc. Now, NSAIDs for neck pain. The most common medication for neck pain, 61% NSAIDs. And we had several patients who were taking NSAIDs for a comorbid condition, also taking them for neck pain. Acetaminophen was the next major category. Aspirin, several patients were using aspirin for analgesia. 10% opioids, and 33% relied on supplements, 8% skeletal muscle relaxants. Duration of neck pain use, 4.3%. Interestingly, we had one patient was using methadone, but they used it on a PRN basis. And I asked, I said, well, how do you know? Well, I would just take it after my exercise class. I got a nice drive home. Now, interestingly, medication practices, self-medication was common. 54 out of 64 self-medicated with an herbal, OTC, a vitamin. Number of prescribers, which this was very interesting. A prescriber could have been a physical therapist, a massage therapist, a personal trainer, or an internet or health food store. They use that very loosely. So greater than one prescriber, 28%. And 9% were using chiropractors as well. And there was one patient who saw a physical therapist 12 times in the past 6 months. And what I found disturbing was internet and health food stores were looked at as a source of authority for many patients. There was one patient that was using a hormone precursor from the internet. And there was no source of medication education counseling listed, and Pharmacist was not listed by any of the patients as a source of education counseling or medication recommendation. Now, chiropractic care was very popular among the elderly, and the literature for musculoskeletal pain and chronic neck pain in particular. There has been several cases of vestibular artery aneurysm after adjustment for chronic neck pain reported in the literature. So you need to use caution if you would have a patient ask you about chiropractic care for chronic neck pain. Use caution. Now, elderly may not disclose the use of chiropractic care or other providers. And the use of chiropractic care or other providers may not get into the medical record. So you may have to probe and ask. And the patient may be the coordinating unit for all of this instead of primary care. And the chiropractor may also be the source of the alternative therapy or medication. And you always have to ask, what's the risk of risk versus benefit? And the chiropractic care is extremely popular. I did a recent literature review in the chronic neck pain and low back pain population. Now, the total number of daily medications was staggering, just staggering to me, unless I'm easily mystified now. But it's 1 to 21 daily medications. I know you in long-term care are not mystified easily, but 5 to 5.3 plus or minus 4 daily medications. These are different medications, and these included OTCs, supplements, and chronic medications, and analgesics. And they took these every day, they stated, the patients stated, participants stated. And as you know, that the use of nutraceuticals or supplements may affect adherence with chronic medications or comorbid medications. Now, the high daily pill burden, of course, we talk about adherence, costs. I don't know how patients can afford this. Also, it really was equal in number, maybe almost 60% prescription compared with 60% OTC with respect to pill burden. And again, potential for drug-related problems. The fall risk just is staggering. Greater than 4 medications a day is associated with fall risk, even though my mother states to me, you can fall too. My mother's 87. So when I point out things to her. Though 38% of our population reported having fallen within the last year. And I thought they were rather young. So there you go, my mother's right. And a lot of those patients with chronic neck pain have balance issues. So common drug-related problems, or DRPs as the students call them, drug interaction was the most common DRP that we found, and it was potential for excessive sedation with an analgesic and a skeletal muscle relaxant, an analgesic with a benzodiazepine, or an analgesic with a sedative hypnotic. Also self-medication, when you did a Pearson product moment correlation or a Mann-Whitney U or a chi-squared, any way you want to do it, depending on if it was parametric or non-parametric. Self-medication was a risk for drug interaction. Also, too, the number of prescribers, if you had 2 or more prescribers, that was also a risk, a significant risk for drug interaction. So we found that over half were at risk for a drug interaction. Non-analgesics were often involved in drug interaction. Surprise, surprise. And also 3 of our patients we found, or participants, if you will, were reported to us on their questionnaires that they had a previous adverse drug interaction, or reaction rather, adverse drug reaction. One had an epidural steroid in the past, and with corticosteroids, and it sounded as if it was a local anesthetic, and they had numbness and rash. Another one had a significant rash and difficulty breathing with a beta-lactam exposure, and another one had a rash with lamictal when they had previously used it with pain, which is not surprising. That's a common reaction with lamictal, lamotrigine. So some of the select drug interactions too we found, I talked about the additive sedation, increased GI toxicity. This was potential with the NSAIDs, especially those using 2 or more NSAIDs for analgesia. We found commonly they would be using 2 as needed, or 1 for a comorbid condition and 1 for an analgesia for neck pain. Increased risk of acetaminophen toxicity. We would find hydrocodone with acetaminophen for analgesia, and then acetaminophen use as needed or just chronically around the clock, additionally for analgesia. Decreased antihypertensive effect. As you know, ibuprofen can cause significant sodium and water retention, and because we had several patients with significant hypertension, we were concerned, we had some with heart failure as well, we were concerned that this could predispose to antagonism of the antihypertensive effect. We had several patients on warfarin, and we were concerned that several of the supplements could cause an increase in their INR, and also we had patients exceeding the 2-gram limit a day for acetaminophen. We had several patients with unopposed estrogen, which we felt that could potentiate for venous thromboembolism. Hypoglycemia risk with some of the herbals and nutraceuticals. Increased risk of hepatotoxicity, again, with some of we had some patients with niacin, we had also some patients with some of the herbals, and increased serotonergic effects with multiple antidepressants. Select DRPs again, duplicate analgesics, dose too low with ibuprofen and naproxen. Inappropriate use, the long-acting opioid as needed with the methadone. Drug use without indication, some of the herbal supplements. No indication for some of the use of the omega-3 fatty acids and some of the herbals, and some of the adverse effects, and also unrelieved pain with the patients that reported still 10 out of 10 after the medications. Now, there's several limitations in our data set. Medication use and adverse effects, that's self-report. We only have what the patient told us. And we couldn't go back and verify the medical record. We did not check pharmacy records. We couldn't speak with their pharmacist. and our physicians. We had no verification of adherence, and we had to just rely on databases for the risks of drug interactions and adverse effects. We did not compare our results to an asymptomatic group. We didn't have a control group of asymptomatic results. Now, our findings for the medications were limited to a single testing session, and we really needed a larger sample to verify. Our N was just 64. And now, what we found too, we have a control group in there that was waitlisted that are treated with exercise. We have yoga and Pilates. Now, some of the patients in other studies in the literature found out when they are in a control group, they're disappointed. And they find out, so they over-medicate with analgesics, or they may take more OTCs. So that may be an effect of being waitlisted to the control group. And also, this group isn't really that ill, or they are highly motivated. They're still out there. We have very few patients who are disabled. There are only 2 patients on disability. The rest of them are working, basically, or they're volunteering in their community. They're a highly motivated group. So this might not really represent the chronic neck pain patient population as a whole. Now, we could say that the majority of our patients did use medications. NSAIDs are the most frequently used analgesic despite limited evidence in the literature. The guidelines state exercise. Also, I was just reading something where cognitive behavioral therapy and addressing the psychological issues of the patient long term, just like in any other chronic pain type of issue or condition is the most beneficial. These are really high-functioning adults with comorbidities that are taking up to 21 medications a day, and we found drug interactions of 50%. So this really points to the need for our intervention as pharmacists, clinicians. And self-medication was a common drug interaction risk. And again, not all participants had complete pain relief, and yet overall there was a 48% decrease. And I didn't show you this, but there was a minimum, like in the literature for like neuropathic kind of pain, it's a 30% reduction, like the neurology guidelines. So we weren't doing too badly with this. Like if you look at the literature, we didn't publish this yet, the findings. So they got like overall an appropriate reduction overall. Gabapentin, pregabalin, and lidocaine patch use was rare in our sample. So, but they're overall like really, they're doing okay. They're not that ill. And maybe since they're out there, they're exercising, they don't want to be self-medicating, or they don't want to take that much medication. So maybe that's what accounts for that PRN dosing instead of that scheduled use of NSAIDs. Think about it. Maybe they don't want to take something around the clock. And we need to really think about optimizing analgesia for the select patient. So again, what is this add to practice? What's the take-home point? These patients are a high medication use population. They have a high incidence of comorbidities. They frequently have more than one prescriber. They obtain products from non-prescription sources. Self-medication is prevalent. There are risks for ADRs, DRPS, and falls. As pharmacists, we need to review, recommend, refer. And we're going to use this to develop interdisciplinary assessments and detect analgesic overuse, drug interactions, adverse effects, and we need to increase our knowledge of medication use in this population and we need to improve patient safety and outcomes. So as pharmacists, we need to educate ourselves, physical therapists, our patients, and we are the medication experts. We need to step up to the plate. Occupational therapists, physical therapists, they, in a well-meaning attempt to improve their patients' care, want to become the experts as well. We need to help them, and we need to take a really active role in medication review, screen and intervene, and develop interdisciplinary relationships. Avoid ED visits for uncontrolled pain. They're so costly. And considerations, depression, insomnia, analgesic optimization, vitamin D. Everyone this side of the northern hemisphere needs to be screened for vitamin D deficiency. And interdisciplinary team approach. Pharmacists and physical therapists are really important players. And sometimes things don't go as planned. And this is from Why Mothers Scream. So when do we refer? Patients with, of course, alteration or loss of consciousness, and suspected infection or sepsis. Anyone that has a script for an antimicrobial or active antimicrobial or fever, they're reporting new onset of pain anywhere in the spine. You need to get them back to their physician because it could be an infectious process or abscess, loss of bowel or bladder control, nerve impingement, new onset paresthesia or weakness could be a problem. You probably need an MR or a physician to assess you. Suspected thrombosis or thromboembolism, and also history of malignancy or anticoagulation therapy. You need to see a physician. And what about the patient that we have just reviewed earlier? Let's just take a little look-see. That's what the pharmacists are ready to do here at the practice site. This is an old photo, but they are counseling and reviewing their patients back in the 40s. So that's what my uncle taught me to do. So anyway, he was a pharmacist. And this case from practice, the counselor with the sedentary work, she had bilateral pain. She thought it was her circulation. And those are all her meds with the issues. And the past medical history with the chronic neck pain, the diabetes, the hiatal hernia, the occasional alcohol, and her meds with the ranitidine, the bivalve patch, the naproxen, the Xanax, and the vitamin D, the lisinopril. Now, the drug use without indication, the omega-3 for increasing circulation. What do you think about the omega-3 for increasing circulation? She tells you that pain is 7 out of 10. You think it's going to increase your circulation? No. Okay. Now, it's used in diabetes, type, 2 diabetes. There's some literature out there, it might help with triglycerides, but the jury's still out too with its effects in type 1 diabetes. And vasodilation, I don't know, it's not a proven indication. Now, considering her past medical history, and she's postmenopausal, and all of her medications there, and it's persistent pain. She's sedentary, and she's also overweight. She was a smoker in the past. Good question. And, it's an untreated indication at leg pain. We can consider DVT, unopposed estrogen, electrolyte imbalance, progression of microvascular disease. These are all the things I'm, running through my head. Progression of pain. She has chronic neck pain. And I'm thinking, well, is there something, is she spinal stenosis even? Is it cervical stenosis? Is it a new, complaint? Adverse effect of non-steroidals, is there something going on? Is she retaining sodium and water from the non-steroidals? What's her vitamin D concentration? Is she even taking too much vitamin D, should we look at, 25 serum, hydroxy, concentration, the vitamin D concentration? Because I had a patient that had vitamin D toxicity. They were toxic and they had pain in the legs and joint pain. And so we're overdosing on vitamin D, so you never know. She's also a fall risk. She's on greater than 4 meds a day. She's on a suboptimal dosage, basically, of vitamin D. Duplicate therapy, NSAIDs scheduled versus PRN. Duplicate therapy, the 2 NSAIDs. Her ranitidine for hiatal hernia, she's taken suboptimal doses of that. She's on a long-term skeletal muscle relaxant. Should those even be taken long-term? She's on a benzodiazepine for sleep. We should monitor her use. She should be considered for sleep hygiene or blood pressure control. I'm looking at the non-steroidal use sodium in water. But what happened to her, she ended up with an electrolyte imbalance. She had hyperkalemia because she started taking a potassium supplement that she had from a prior hospitalization, and she just started taking K-Dor that she had and thought it would be a good idea to supplement her potassium because she heard that leg cramps could be due to low potassium, and her potassium was 6. And she disclosed this later on, and she had hyperkalemia. Okay. So anyway, you just never know what people don't tell you. So it was just an old prescription that she decided to restart. And it was just enough for her with the lisinopril, the potassium-sparing diuretic. So, but she still has a lot of fine-tuning to do. We recommended that she be tapered off of the benzodiazepine, use sleep hygiene, and have the ranitidine prescribed on a regular basis. We instituted 1 NSAID. We instituted Xanaflex daily, and then eventually had her changed to a TENS unit with physical therapy. We double-checked her vitamin D serum concentrate stores, and it was fine, and we continued her on that, and we had her on a regular blood glucose monitoring. Her hemoglobin A1C was fine, and we referred her to, she went on reproendocrine, so she was taken care of from that aspect, who eventually tapered her off the Vidal-Dot. So long-term skeletal muscle relaxants probably just contribute to fall risk, and TENS units are effective for this population, as well as heat, exercise. But this patient had a lot going on, but she was using potassium. She disclosed it.